And good evening, everybody, and welcome to the Oculus webinar series. My name is Dr. Bill Tulo, Medical Director at Oculus, and I'm really excited tonight for several reasons, one of which is one of my favorite topics, navigating keratoconus treatment options with the Oculus Pentacam AXL Wave, and two of my favorite speakers, Dr. Greenstein and Dr. Gelles. Before I introduce our speakers, and it's a little bit of housekeeping, we encourage you to ask questions, but put them in the chat box and I'll compile them and we'll answer as many as we can live at the end of the talk, and any that we can't answer, we'll answer via email if we run out of time. So tonight, let me introduce my first speaker, Dr. Stephen Greenstein. He's a graduate of Harvard Medical School's Cornea Refractive and External Disease Fellowship at Massachusetts Eye and Ear Infirmary. He's currently the medical director of the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus. He's authored articles and book chapters on corneal cross-linking, and he's co-invented corneal tissue addition keratoplasty, or CTAC. Dr. Greenstein is board certified in ophthalmology and refractive surgery and is a clinical assistant professor at Rutgers, New Jersey Medical School. He's a member of several ophthalmology societies and serves as an ophthalmologist for the New York Jets football team. Dr. John Gelles is the director of the Specialty Contact Lens Division of Cornea and Laser Eye Institute and the CLEI Center for Keratoconus in Teaneck, New Jersey. He's an assistant clinical professor at Rutgers, New Jersey Medical School in the Department of Ophthalmology and Visual Science. He is also an adjunct clinical professor at the State University of New York College of Optometry, Illinois College of Optometry, and New England College of Optometry. With no further ado, Dr. Greenstein, Dr. Gelles, take it away.
Thank you, Bill. It's great to be here tonight, and thank you again to Oculus for inviting us to come and speak on one of the topics that both of us are most passionate about, which is managing keratoconus. So for tonight, we're going to talk about navigating keratoconus treatment options with the Oculus Pentacam AXL Wave, which has really helped both us as clinicians and I think patients understand their disease much better. So modern keratoconus management really breaks down into three steps that we've sort of coined the KC 1, 2, 3 approach. And although every keratoconus patient isn't going to require all treatment for all three of these portions of their disease, you have to consider each aspect of a patient's keratoconus to decide what the best approach is for each individual patient. And so we always consider the stability of a patient's disease, how can we improve the patient's curvature and topography, and of course, most important, how are we going to improve a patient's vision? When it comes to stability, we all know that the game changed for keratoconus when corneal cross-linking was FDA approved in 2016. As we all know, its indications are for progressive keratoconus in patients who are older than 14 years old, although I think there's nobody who would argue that treating a progressive patient under the age of 14 shouldn't be considered off-label, and it is also approved for corneal ectasia after refractive surgery. And what we saw early on was that corneal cross-linking did a really great job at stabilizing the cornea and even improving some of the corneal metrics that we classically would look at for patients with keratoconus. So maximum keratometry, the steepest area of the keratoconic cornea, on average flattened by about a diopter and a half 1 year after cross-linking. In general, the keratoconus indices, which were measured on the Pentacam, significantly improve after corneal cross-linking. And both uncorrected and corrected visual acuity improve by more or less a line, a little less for uncorrected and a little more for corrected visual acuity 1 year after cross-linking as well. Now, what we looked at was we were the first to report on some of the long-term data on corneal cross-linking, which were for patients who participated in the pivotal trials in our single center. And we recalled all the patients who had participated in the original corneal cross-linking trials, and we had them return for a 10-year follow-up visit to see how they were doing. And what we generally found was that the patients were doing remarkably well, particularly the patients who had keratoconus. When we looked at best spectacle corrected visual acuity, 86% of all patients remained stable, meaning they did not experience a worsening of greater than or equal to 2 lines of vision loss over that 10-year period. Actually, 100% of the patients with keratoconus had remained stable, with just over 70% of the patients with corneal ectasia remaining stable as well. We then looked at our primary metric for keratoconus from the original studies, which was maximum keratometry, and we found a pretty similar result. Just over 75% of all patients remained stable, meaning the Kmax did not steepen by more than 2 diopters over that 10-year period. Just over 85% of keratoconic patients remained stable, and just about 2/3 of the ectasia patients remained stable. And what we added to our analysis, which was recently published, was the newer Bellin ABCD progression display, which is available on the Pentacam AXL Wave. And what we found there was very similar to our other results. About 80% of all patients remained stable 10 years after cross-linking, with just over 90% of the keratoconus patients remaining stable, and again, just about 2/3 of the ectasia patients remaining stable. So our general take-home was that overall, the patients were doing well after cross-linking. Clearly, the keratoconus patients were doing very well, with almost all remaining stable about a decade later. For the patients who have ectasia after refractive surgery, they clearly do need to be watched more closely, with more of those patients experiencing progression and requiring, in some cases, a repeat cross-linking. Now, one of the things that we have found very helpful in our clinic is the Bellin ABCD progression display, because it's a display that really synthesizes a lot of data onto one screen, making it a lot easier for a clinician to really analyze what's going on in a patient's cornea over time. And actually, it's turned out to be a very useful educational tool for patients to be able to sort of see these displays and see whether or not their cornea is changing and understand the treatment decisions that you may or may not be making based on these results. And what this display and what the analysis looks at is it looks at the curvature through a regression analysis around the thinnest point of the cornea. So really in the area of the cone and in the area of the keratoconus, that's where it's focusing all of the analysis. And then it takes that analysis and compares it to both a normal population, which is listed in green, and a more specific keratoconic population with a confidence interval to tell you whether or not the change that you're seeing in a patient's cornea meets the confidence interval for progression. So as you see, each colored on this map here is an individual patient visit, and the first 2 visits that this patient had 1 year apart were basically more or less the same, with the curvature looking pretty stable, maybe seeing a little bit of change in the posterior curvature, which is the B middle portion of the graph. And then clearly over the next time frame, seeing a significant amount of progression, which is passing the 95% confidence interval in all the anterior, posterior curvature and corneal thickness in a patient who may require then additional cross-linking. And what's been added to the display even further is not just looking at a keratoconic population alone, but looking at specifically a population post-cross-linking, and that's what you can see in blue. So the dotted black line indicates the date of cross-linking. Every visit, every colored bar after that is then a post-op visit from their cross-linking. And starting about a year after their cross-linking, the Pentacam will set that as the baseline metric and then compare every exam after that with the new baseline metric against a post-cross-linking population. And so here's the case which we see unfortunately too often, where a patient sometimes gets lost to follow-up, and you can see that this patient had a mild keratoconus when they were first seen, with a definite steepening of their Kmax. And then when we look more closely and we compare their analyses, which can easily be done on the Pentacam, you can see that there's clear inferior steepening, there's clear change in an increased anterior elevation, clear increase in the posterior elevation with corneal thinning and that steeper Kmax. And this is clear progression that we would all diagnose and recommend cross-linking for this patient. Once again, though, the ABCD analysis really does a nice job of showing those visits, showing that clear progression past the 95% confidence interval for this patient, and again, a really good educational tool for the patient to be able to see that progression on display. But other times, it's not going to be as clear, and we also know that it's pretty common to see this case where we see a case where Kmax has really not changed very much over the interval visits. But when we look more closely, we do see that there's sort of a little bit of against the rule axial steepening. We see that there's a little bit of change in anterior elevation, a little bit of change in posterior elevation, and no real corneal thinning, no change in Kmax. So we sort of have metrics that are a little bit all over the place. And these are the patients that concern us because we're not entirely sure what to tell them about the progression of their disease. Well, again, the analysis here really does help us out a lot. When we look at the anterior curvature and the thickness, both have changed a little bit, and they are moving towards a steeper curvature and a thinner cornea, but they're neither of which really meet that progression confidence interval. But we do see that clearly there has been posterior change in this patient's cornea. If this is a young patient, we might recommend cross-linking, or at a minimum, we might recommend very close observation to make sure that there isn't true progression for this patient. And even for a patient who might be in a more stable phase of life, we're going to monitor this patient closer than we would normally to make sure that we're not seeing any true progression. And really, it synthesizes that data very nicely all together. Here's actually a patient who came into our office yesterday, and we all see these patients on a regular basis, where we have a patient who's a 19-year-old in college. He went for a new pair of glasses, and he was told that he had this small change in his cylinder correction and his astigmatism in his glasses. So of course, I got an immediate panic phone call from the patient's mother that his keratoconus must be getting worse. Can she come right in? So of course we told her she can come in and have her have the cornea, her son's cornea checked. When we look again at a typical comparison analysis, looking at 2 time points, we can see this patient had very good flattening. This was before and after cross-linking, with about 2 diopters of flattening, so that was very encouraging. Really no significant change on their anterior elevation, no significant change on their corneal thickness maps. And then we go back and we compare to the last time the patient was here. So we run a more comparison analysis. We again look at the axial curvature, looks pretty stable here. The anterior elevation also pretty stable, posterior elevation pretty stable, and thickness pretty stable as well. So we would be able to run through all of these maps and tell a patient that we thought that their cornea was stable after cross-linking. They did have this small change in their glasses prescription, but for now, they should stay on their regular course of follow-up. But as you can see, it's almost dizzying to keep looking through all of the different compare maps to try to figure out whether this small change might represent a progression of their disease. But when we look at the ABCD analysis, and now with the cross-linking markers in place, we can see that it's more clearly defined for this patient. This patient clearly has a stable curvature in their anterior posterior cornea and their corneal thickness, and none of their new metrics for this time point in pink cross the 80% confidence interval of progression. And this was a perfect display to show the patient and to show his mother that everything that we're looking at looks really stable, and giving them some comfort and comfort for him to go to college, although he didn't seem too concerned himself. Although the ABCD progression display is very helpful, and we've gone through a lot of the positive aspects of monitoring progression with it, there are certain cases where I do find that you have to be a little bit careful when you're looking at the analysis. And this is one of those cases which also came in yesterday to our office. And so if you were going to look at this patient's left eye, there was a question about whether or not he was having a little bit of progression. If you bring up the ABCD analysis, I would look at this and say, for the most part, this patient looks very stable. their anterior curvature, their posterior curvature, if anything, looks a little bit better. As bars move to the left, that means they're actually flatter. And their thickness does look like it's changed, although it kind of looks like it bounces around. And I personally find of all the measurements, the thickness without any change in the curvature is not the best indicator of progression. So I would look at this and be fairly reassured that this patient seems pretty stable right now. Then you look a little bit further, you dive a little bit deeper into their analysis, comparing again their exam from 2021 to 2023. This patient had not followed up actually for 2 years. And if you look at their Kmax, you'll see that there is a little bit of steepening. Kmax does not turn out to probably be the best metric to monitor progression, because it really is just looking at one point in the cornea. And so sometimes that point can shift around, and then you're not looking at the same point in the cornea. And so flattening or steepening doesn't necessarily indicate progression, but there is any steepening that you see should at least warrant looking further into the patient's topography and change. If we look at the axial maps, now I was getting a little bit more concerned. We are seeing some infratemporal steepening, which is pretty classic for keratoconus progression. I look at the elevations and I'm seeing, again, nothing jumps out as terrible, but a little bit of additional anterior elevation, a little bit of additional posterior elevation, and also a little bit of thinning. So now this is starting to come together a little bit as what does look like some progression in all of our normal metrics. And this is where it's very important to highlight one thing when you are looking at keratoconic maps, and that is looking at the patient's thinnest point, and the Pentacam gives you the actual location of the thinnest point, and it also gives you the location of the maximum keratometry, which I was hoping would zoom in, but I guess that portion is not up. There we go. Okay, so if you zoom in on those metrics, what you can see is that the thinnest point is really above the maximum keratometry. So the Y coordinate for the maximum keratometry is well below where the thinnest point is. And remember, the ABCD analysis, really its basis is focused in the thinnest point of the patient's cornea. So if that's where the analysis is focused, sometimes for patients who have more of a pellucid pattern to their disease, where the thinnest point might not exactly correlate to their steepest point in the cornea, the ABC analysis can sometimes miss some early changes in the cornea, and it's just something to be aware of. So for most and classic keratoconus patients, it works really, really well. But this is one metric that I do look at to make sure that when I'm looking at that analysis, I can be confident in the results that I'm seeing. So we've seen that, and as we know, cross-linking has really revolutionized the management of keratoconus when it comes to stability. The long-term results look very promising for stability with cross-linking, and with our newer ability to analyze not just one point in the cornea like maximum keratometry, but a whole array of data about the keratoconic cornea, we really have a lot more that we can work with to determine whether or not a patient is stable and requires cross-linking at all, and whether or not after cross-linking they require a repeat cross-linking. But in addition, keratoconus management has really been revolutionized in our ability to improve corneal curvature for our keratoconic patients as well. And one of the ways where we've really seen some very impressive results in improving patients' corneal topography is with a topography-guided laser and particularly topography-guided PRK for keratoconus. In the US, we use Placido imaging, which will then be uploaded into the laser, which is available on the WaveLight Alcon platforms. And then an ablation pattern is created within the laser to try to flatten the steep portions of the cornea, steepen some of the flatter portions of the cornea, and create a more symmetric central cornea for our patients. Now, it's important to know that in the US, topography-guided PRK in general is off-label, and for keratoconus, it is off-label as well. One of the things that we've really been encouraged by is a transepithelial PRK, or a transepithelial approach to treating our patients with keratoconus. And the keratoconic cornea, in particular the epithelium of the keratoconic cornea, is perfect for transepithelial PRK, because the epithelium over the cone, over the steepest portion of the cornea, tends to be thinner than the surrounding corneal tissue. So when we ablate the cornea without manually removing the epithelium, the excimer laser is going to hit the stroma of the cornea before it's going to hit the surrounding tissue. And so it allows the action that we see and the flattening action of the laser to really be focused primarily over the area of steepening and over the cone. In addition, for a lot of our patients who have more moderate cases of keratoconus, where the laser is calling for significant amounts of stromal ablation, using the transepithelial approach allows us to still run those ablation patterns effectively without removing nearly as much stromal tissue as would normally be required. And here are some of the cases that we've performed topography-guided PRK. This is specific to the cases where we performed topography-guided PRK simultaneously with cross-linking, which in many cases we've had very good results with. We actually just recently presented those results at the last ASCRS meeting. But here's where we use the transepithelial approach in a more moderate case, and you can see the clear flattening right over the cone of the cornea with some corresponding steepening. So you're really getting a nice symmetric central cornea after treatment. More mild case where, again, the cornea here is even more symmetric. And finally, an even more mild case where in many ways, if you saw the patient's post-op cornea, you wouldn't even necessarily know that the patient originally had a very clear case of a keratoconus. So the excimer laser, particularly with topography-guided software, has become a very, very powerful and useful tool for treating patients with keratoconus, for making their corneas more regular, to improve their vision in glasses, to improve their vision in soft contact lenses, and in some cases, as was the case at the bottom, even improve their uncorrected vision well beyond anything that we used to be able to do. And while we've always used a topographer and we've used the Pentacam to be able to look at our data over time and compare our topographies and tomographies over time, with the AXL Wave, we can now look at the aberration profile much more clearly and how that has improved and changed over time as well. So for this patient who had that remarkable result after a simultaneous treatment, you can also just see how much his higher order aberrations reduced after his treatment was performed. So this is 1 year after his treatment, and his total aberrations have improved by more than half. His coma aberrations are about a third. So you can see why he would notice such a impressive result. And one of the nice things for patients is you can actually show them on the visual performance display, you can show them some of that change as well. So while this patient doesn't have a perfect cornea, and one of the things that we're hoping that will also be improved in the AXL Wave is right now some of the aberration profile still takes into account some of the lower order aberrations and some of the spectacle prescription, but you can clearly see that the corneal aberrations for this patient have improved significantly when you look at the visual performance and the total aberrations as well. And a patient can look at this and they can really tell the improvement that their surgical treatment has offered. So again, very helpful for the clinician, but also very helpful on the educational side for patients. One of the procedures that we're most excited about is really the advancement of corneal inlays, in particular corneal tissue inlays for keratoconus and for remodeling patients' corneas with these corneal tissue inlays. And CTAC is one of the available modalities to treat and to improve patients' corneas. As Dr. Tullo said, I'm one of the co-inventors of the CTAC technique. And the CTAC is corneal tissue addition keratoplasty, where we use a preserved corneal tissue, which is gamma irradiated and provided by Corneagen. So it is a decellularized corneal tissue. It's actually shelf stable. It can be stored on a shelf for up to 2 years. It's shaped then with a femtosecond laser. These are shaped with the Zemer LDV8 laser. And because of its gamma radiation process, it actually has some additional rigidity to it compared to fresh tissue, which has proven to be helpful, inducing some of the corneal flattening and also just some of the ability to use it and place it in patients' corneas. And you can see in this slit lamp photo here, really how much these corneal inlays can change the shape of the cornea almost immediately post-op. So this is an immediate pre-op and an immediate post-op picture after a CTAC segment is placed. This is a patient with a clear, steep cone, which can be seen on the left. And when you place the inlay, the cornea is almost takes on a normal and obviously clearly flatter contour. And as the epithelium heals into some of these areas, you can really see some very smooth central results after CTAC placement. And once again, you can see the thing that we are tremendously excited about when it comes to these corneal inlays is really the diversity of treatment. So while something like PRK can be limited by corneal tissue thickness, clearly we're not going to ablate corneas that are too thin or we have to ablate too much tissue. CTAC is not limited by corneal thickness, and it can be modulated so that the flattening can be either increased for patients who have severe disease, as you see up top, and decreased for patients who have more mild disease, as you can see down below. And the very encouraging part and really amazing part, which was shocking to us at the beginning and has now become actually routine from placing them, is how reproducible the post-op corneal maps look. So when you look at the center of post-op pictures, you can see that almost every one has the same regular astigmatic appearance after the segment is placed. And this is what's really led to us seeing some of the really amazing and robust results that we've seen from these corneal inlays. And again, one of the nice things on the AXL Wave is that we can use topography overlays, and in this case, densitometry overlays, and we actually look at our placement of the segment on the cornea relative to the pupil and relative to the topography maps that we see up top, which can really confirm that we've placed segments in the proper orientation and where we want, and as well as even show that to our patients. We just recently, and was very exciting, we published the first results from our prospective CTAC trial, and it actually was featured on the cover of this July's JCRS. And this is what we've seen, and when you see this, you can see why we were so excited by the results we were seeing. When it came to uncorrected vision, we were seeing an average improvement of almost 6 logmar lines of vision. So there's really nothing out there, maybe short of corneal transplant, where we've seen any kind of improvement in vision like this. And when it came to glasses vision, spectacle correction, we were seeing on average about 3 lines of improvement as well. So we were taking these severe keratoconic patients who had about 20/80 vision on average to start, and we were their average vision when they were had a CTAC placed was around 20/40, which is a very, very functional vision. And it's important to note, and Dr. Gelles is going to go over this in just a bit, when it comes to vision correction, a lot of these patients still wore contact lenses for their primary vision correction, and their contact and their vision was excellent in those lenses. But having 20/40 spectacle correction really allowed these patients to function without their lenses. So they could take them out at night, they could take them out on a weekend, and if you have 20/80 vision with your glasses, you feel pretty dysfunctional, and so you're going to rely on wearing your contacts pretty much all the time. But if you have 20/40 vision, you can really take out your contacts for the times that you feel like you might not need them as much and really give your eyes a break. And we think this is going to be very important to really allowing these patients who have worn their contacts for 12, 14, 16 hours a day to really be able to wear them for a much longer term over their life. Again, these were results like we had never seen with any other procedure. We were seeing not only vision improvement and spectacle improvement, but we were seeing real significant improvement in glasses prescription and in our refractions. So much so that the average spherical equivalent had improved from somewhere around -6 to about a -1.5. And as anybody knows who's looked at keratoconic data, a lot of the times when you look at manifest refractions and refractive data at all, it's very, very variable. And it's very hard to see significant results in refraction data for keratoconics patients. So this was really very remarkable. And of course, we were seeing significant amounts of flattening, which explained all of the visual improvement. But again, the most important thing with CTAC is not so much the average flattening, but it's the customization of the flattening. So not every patient is going to need a maximum amount of flattening. So while we looked at a patient before who had almost 20 diopters of flattening, and we can certainly induce sometimes pretty reproducibly 15, 16, 17 diopters of flattening, some patients only need 4 or 5. And so it's the customization of the segment to get that flattening that we actually want for each patient that has really proven to be the most remarkable thing about the segments themselves, and also what has led to some of the reproducible vision that we have seen. So, we've seen how stabilization of the cornea has changed over time with cross-linking. Clearly, our ability to improve corneal curvature and corneal topography over time has improved as well. But most importantly, what we are looking to do is improve patients' vision. And while Dr. Gelles is going to talk mostly about how we're still doing that with contact lenses and really a unbelievable contact lens technology, which has allowed us to improve patients' vision and keratoconic patients' vision in ways we never imagined, we're also able to do this now surgically because we are able to stabilize the cornea and because we're able to improve corneal curvature. So I wanted to kind of leave off with this case because I think it kind of walks through some of the things that we've gone through tonight in terms of management of keratoconus and also some of the utility that the AXL Wave has in managing these patients as well. So this was a recent patient who I had seen, and he was a 69-year-old male with a history of keratoconus, and now he was having worsening vision in his contact lenses in both eyes. He was a scleral lens wearer, and his main issue was that he was developing cataracts. So as you can see in his glasses, he's very anisometropic, and his spectacle correction is okay in his right eye, not much better anymore between his spectacles and his contact lens in the right eye. And then his spectacle correction is really not adequate at all in the left eye. And that disparity between his spectacle correction and the contact lens correction does indicate that there is room on the cornea, not just from the lens standpoint, to improve his vision. So we look at the 4 maps refractive. This is usually our starting point on almost any keratoconic patient that we're looking at. And you can see that in the right eye, this patient really has more of a form first keratoconus. They have some central steepening with very, very mild anterior and posterior elevation in those areas, but really no significant islands to speak of, no significant thinning. So, by definition, patients who have keratoconus, we consider having it in both eyes. He definitely has some signs that we would kind of put into maybe the form first category, but not much disease there. But clearly in the left eye, we can see a much more typical keratoconic pattern with typical inferior temporal steepening, a typical anterior and posterior elevation, right in the corresponding areas of thinning. And again, when we look at the visual performance display, which I find very helpful for educating patients on their disease, but also even looking at it from the clinical standpoint. You can see that there are corneal aberrations from his keratoconus. There are internal aberrations that are coming from his cataract, but really his corneal aberrations are still the significant component to what is contributing to his difficulty with spectacle correction, at least in his left eye. So we had an extensive discussion with this patient about his options. Of course, one option is to do cataract surgery and then wear be refit for his scleral lenses. But with the opportunity to improve corneal curvature nowadays, I discussed with him performing topography guided PRK to improve his corneal contour before moving forward with cataract surgery. So we did perform the topography guided PRK, and you can see a much flatter, a much more symmetric cornea to the left, with the corresponding flattening and steepening in the difference map to the right. And when we look at that same visual performance display, this is only after topography guided PRK alone. No cataract surgery has been done yet. You can see that on the cornea side, doing the corneal correction, doing the corneal surgery has made his corneal aberrations, his visual performance, much clearer on the cornea. He still has his lenticular aberrations from his cataract, but overall we've improved his aberration and visual performance significantly by just performing the topography guided surgery. And now we can use the axial length from the AXL Wave and the analysis of this complex cornea to generate our toric lens calculations for planning this patient's cataract surgery. So now in this one device, we can do all of the planning. We can do the planning for his topography guided laser, and now the planning for his cataract surgery. And we put toric lenses in both his eyes with the goal of a blended vision, the vision distance correction in the right eye, and a intermediate to near correction in the left eye. And this patient went from being a scleral lens wearer with 2200 spectacle correction in his left eye, 2040 spectacle correction in the right eye, to 2025 uncorrected distance vision and J1 binocular uncorrected distance vision. And being able to work through our process of stability, curvature, and of vision correction really allows us to achieve results that we never used to think were possible for these patients. So with that, I will turn it over to Dr. Gelles, and he will really discuss what is still the bread and butter of our vision correction, which is the amazing contact lens technology that he's been working with.
Excellent. Thank you so much, Stephen. Let me go ahead and get our presentation going here. And everybody seeing my screen right now? Good.
Yes, we
Okay.
can.
Yes.
Excellent. Very good. Thank you. Excellent. So to kind of mirror what Dr. Greenstein has had said previously was, we can do some really great stuff with contact lens technology. But one of the things that I really want to acknowledge in this is the importance of being able to collaborate together and how we can improve outcomes even with that. This is one of the most recent publications that we had put out, which is just a case study that was written by Dr. Roll, one of our former residents from Rutgers. But what we looked at here was an individual who had failed multiple different types of contact lenses. This individual had worn corneal gas permeable lenses in the past, which were discontinued due to spontaneous ejection of the lens and discomfort with the lens. He had later been put into piggyback lenses, which also failed, and then had tried soft, but had inadequate vision with those, and then was placed into hybrid lenses, which had worked pretty well for several years. But then he came in with signs of overwear and pain in the eyes from overwearing the lenses, with an average wear time of about 16 hours per day. I went ahead and refit him into a scleral lens, but even though he was 2025, 2030, he was unhappy with the vision in those and thus preferred to tough out the discomfort with the hybrid lenses in favor of the clearer vision. What was then done was he was referred to Dr. Greenstein to have topography guided PRK performed, in which case you can see we regularized his cornea. And after the procedure, we were able to go ahead and correct this individual with standard soft lenses and achieve a level of visual acuity that was actually better than what he was getting with his hybrid lenses. So there's some pretty good synergy by working together in this and utilizing these surgical techniques to improve corneal curvature and thus allow us to use simpler lenses and even get even better outcomes than what we can get in some of the complex lenses. Now, with that said, Dr. Greenstein also said one very important thing in that too, which was the variability of refraction. So I do want to review how we do refraction in our practice and to also touch on a publication that we had published this month as well, which was correlating manifest refraction and SIMCAs to tomography characteristics in patients with keratoconus. What we found was in this paper, we looked at about 1,000 eyes of patients with keratoconus with varying levels of severity. And what we did was we looked at their simulated keratometry, their manifest refraction, and compared that to metrics of keratoconus. One of the big ones, we looked at the correlation between these metrics and the maximum keratometry and thinnest pachymetry. What we found, which was very interesting, was that Ks, these simulated Ks, which are really derived from the central 2 to 3 millimeters of the cornea, are poorly correlated with the severity of keratoconus until the level of keratoconus reached over 60 diopters of K max. So when we saw this, what this is telling us is in clinical practice, using your simulated Ks and saying Ks over 47 is very important to finding keratoconus. It is not very well correlated until the disease is very, very severe. What we did find, though, that was clinically significant at all levels was the finding of an against the rule or oblique manifest refraction with 2 diopters or greater of cylinder. So if that cylinder was located in against the rule or oblique fashion, those individuals were consistent. Now, this wasn't a prospective where we looked at eyes that had against the rule or oblique astigmatism with greater than 2 diopters and found how much of a percentage of that population had keratoconus, but we found this against the rule or oblique astigmatism with 2 diopters or greater being consistent in all levels of severity of keratoconus. So this was very important, and this may be a very low-tech way for us to suggest the need for screening with topography. Now, how do we refract? Let's get into some technique here. What we do is we look at the keratoconic topography, and what we're looking for is an axis of symmetry. So where can we cut the cornea and make the left look like the right or the top look like the bottom? Essentially, where can we cut it so that the cornea looks symmetric? What we do is we then use that axis as the cylinder axis for our refraction. What we found in our study was that -3 cylinder tended to be about the average amount of cylinder. So when we look at this, what we like to do is for patients that we can't get a good autorefraction or a reliable autorefraction, or getting very odd refractions from other individuals, is what we'll do is we'll take the individual, we'll show them a 2400 letter, we'll put plano -3, and we'll line it up at the axis of symmetry, and then we'll start using 3 diopter movements, and we'll start in the plus direction. What we found in this paper was actually that there was a large percentage of individuals, much higher than you would think, that actually had hyperopic spheres or hyperopic spherical equivalents or mixed astigmatism. So this was actually a very, very interesting finding. So what we do is we start with these 3 diopter movements, and then when we're going to refine our cylinder, we actually don't use the JCC at all. We just use large movements on the cylinder and then have the patient subjectively find their axis, as well as us kind of using that same technique. Let us know if it's getting clear. Did I go past the clear spot? Cool, let me go backwards and then find, kind of whittle that down until we end up using our forced choice to a point where we found our final refractive result. And this technique works very, very well. All of our technicians are using it, and myself and Dr. Greenstein use this frequently in clinical practice. Next, what I want to talk about, though, is technology-driven prescribing of contact lenses. This is very, very important and very impactful. This is where we start to find where we can troubleshoot individuals that we would have had a hard time with fitting, or individuals where we want to improve their visual acuity even further than what we thought was possible. So we've known for a while that we can use topography-driven prescribing with one of the Oculus subsidiary companies, Wave contact lenses. So what we can do is take the topography derived from the Pentacam and import that data into the Wave software, and then be able to design a customized lens to the shape of the cornea. What you can see here are two simulations, one of a toric lens on this keratoconic eye, where you can see a tremendous amount of pooling in this area of clearance in the superior. Over here is the superior, and over here is the inferior on this simulation. And what you can see is down low, we have an area of excessive edge lift and a point of bearing, and that can be seen in the simulated fluorescein here. Well, what we can do is create what we call a freeform lens that takes into account the abnormal geometry of the cornea and then mirrors the lens posterior surface to help align the lens to the eye. And what you can see here is once we've used a freeform geometry, we're able to create a lens that thus no longer has bearing or inappropriate clearance in different areas. This is truly a lens that can align to the eye. So what has been the really unique variable, we've known that this has been around for some time in the corneal space, but what we've now been able to do with the CSP software on the Pentacam, on Pentacam Classic, but the Pro version specifically on the Pentacam Wave AXL, is we can map beyond the cornea onto the scleral shape as well, so that we can image the entire ocular surface, and thus we can use this information to help us either select scleral lenses or even create technology-driven scleral lenses with freeform geometry. In the original CSP, we would do 5 different images and stitch those images together to be able to create the ocular surface geometry that we see here. With CSP Pro, though, we get a wider scan with higher resolution. Now, this software is only available on the Pentacam Wave AXL, and we're able to get this in a single capture. And within the programming of the way that we take scans now, if we run a full sequence, CSP is an option in the tomography area, so we can just click that on and do this just in line with all of our other measurements of, biometry, wavefront aberrometry, and tomography. So we can kind of capture this in, kind of all of a day's work. So how does this work? Basically we're taking these large cuts all the way out to the sclera, and what we're getting are these individual slices, and we get image review over here, so we can see each one of those individual slices present. And what we get is a high intensity slice and a low intensity slice. High intensity slice so that we can see where the corneal shape is, and low intensity so we get less flare off of the sclera. After we get that, then we can derive a couple different images down here, a coverage map to say, okay, we got full coverage of the cornea and sclera, and over here, some data about the way the eye looks compared to a best fit sphere. So let's go into this a little bit more. What we're looking for is complete coverage, and then we're looking for any artifacts that may happen within the corneal profile. We want to look for broken lines or missing data. If we have missing data, what we can do is just simply run another scan, and then those scans can be stitched together to complete the areas of missing data, like what you see here in the blue. Now, next what comes up are the scleral parameters. Here we can look at the angles and elevations of the sclera, and then we can look at the scleral elevation map. Based on this, I use this in clinical practice to help determine whether or not I'm going to use a diagnostically fit lens, and if that's going to be successful, or I'm going to use a free-form geometry. For instance, in this eye over here on the left, we can see that this individual has a very symmetric scleral shape. What we can see is that there's quadrants of elevation and depression. This eye we would use a quadrant specific design on, where we can basically get a standard lens to work pretty well. Now on the other side, you'll see that there's inconsistent geometry here. There's nothing there that really says, okay, there is, a clear periodicity to this or clear irregularity to this. When we look at this, we can see that this is just very asymmetric, and this eye would be best served by being in a free-form design. Again, we can have another one here where we look at this and say, this is relatively symmetric, but we start to have some asymmetry as we get over to looking at this horizontal meridian. And in this eye may be best served in a free-form design, whereas the image to the left here is also going to be best served by a free-form design as well. So I need to get rid of the image of myself here. Hang tight. There we go. And perfect. So when we get into, there we go. Some of the data that we've looked at, we did a couple different studies looking at diagnostic scan data and using this into lens calculators CSP data and entering that into diagnostic lens calculators to help us select a first lens, and then looked at data generated design. So first, what we're going to look at is the use of trial lenses. What we did was we compared myself, or rather, I think this was actually one of my interns. And what they did was we compared the ability to select a first lens and put that on the eye and have an acceptable start point. And then we compared that to taking this data and importing it into a lens-based software that would help select a recommended trial lens. What we did was, for the practitioner, we found that 3 eyes, so we did this on 6 eyes, and just did a crossover with this. 3 of those eyes required 2 lenses when it was done by the practitioner, and then the fellow eye required 1 lens. And that was allowing us to get clearance between 200 and 500 microns. With the CSP Pro software, all 6 eyes only required 1 trial lens to go on the eye, and the clearance of those lenses was between 200 and 300 microns. So the CSP, even in a very small data set, was statistically significantly better, and really it was proving it. You're able to do this with just 1 lens. The other thing that we did was we looked at data-driven design. So what we did was we looked at 31 eyes that had previously failed scleral lens fits that were performed diagnostically. And what we did was we then went on to fit these individuals with scan-based lenses using CSP software. And what we found was that we were using or getting success in these individuals with anywhere from 2 to 3 lenses. So it was a superior way to fit lenses here. Now, when we look at the various different shapes that can be derived by using the CSP software, we can get a variety of different geometries here. So here's a case. This was an individual that I struggled with significantly. And what we did was we went ahead and scanned this individual with CSP software, and then we exported this into the Boston Sight scleral software. So this individual, I had struggled with them. I had gone through 6 different lenses before I said, okay, enough's enough. We need to stop wearing this lens for a while, let your scleral shape go back to normal, and then go ahead and scan you and make a lens. And what you can see was this was his lens after he had been out of it for about 2 weeks. And you can see just how irregular his scleral shape is. We would have never gotten a diagnostic lens to fit this eye. So what we did was we went ahead and derived these lenses here, and we nailed it with the first set. This individual was exceptionally happy. And if we had started actually with the CSP lens, software, we would have gotten the first time. But it took actually 7 lenses to get to this endpoint where this individual is looking quite good. Now, however, we will still run into those individuals where they go, "Doc, my vision is still blurry," right? So what we looked at was, why do individuals still have problems with the residual aberrations? And this is where wavefront guided scleral lenses can come in. When we do wavefront over a contact lens, what we can see is that aberrations are reduced for the individual but not eliminated. And there are 2 sources for that. One is the decentration of the lens to the line of sight. The other is that we're masking the anterior surface of the cornea and now revealing the posterior corneal aberrations. So what we have now are the ability to create wavefront guided optics on scleral lenses, and that can truly improve the quality of an individual's vision. On the left, you can see the simulation of the scleral lens, standard traditional scleral lens optics versus the wavefront guided optics on the same individual. And you can see in the simulations here, it's significantly clearer for the individual. So how does it work? It works by providing disruptive interference. So kind of think of it similar to noise canceling headphones, where we create an equal and opposite sound wave to cancel out vision. We're doing the exact same thing with light. So when we take the individual, this is the process here. They wear a scleral lens with a dot matrix on the front surface. We use a wavefront aberrometer to then go ahead and measure the aberrations of the total eye with the contact lens on. So we map that out. We then create an inverse of that data and manufacture it into the anterior surface of the contact lens as a method to kind of cancel out those aberrations. And when they wear the contact lens, those 2 aberration profiles cancel each other out and thus create an improved quality of vision. So this is just a quick case here. This is a 47-year-old patient with keratoconus. They wear scleral lenses currently. They're 20/25 in both eyes and 20/25 plus with their scleral lenses, but they're seeking visual improvement. They're still very unhappy with their vision. This is what their corneal topography looks like. You can see clearly keratoconus here. And this is what their aberrometry looks like on the Wave AXL. What you can see is at a 5.5 millimeter pupil, they have 4.6 microns of aberration in the right eye and 0.38 on the left eye, and they're unhappy at 20/25 plus. What we then did was create a wavefront guided scleral lens for this individual using the OVIDS platform. And using this OVIDS platform, what we were able to achieve was 2015 minus for the individual. And we reduced their aberrations by 40% in the right eye and 37% in the left eye to be able to improve that quality of vision for the individual and make them happy. Now, what you can see here is a comparison of the point spread functions on each eye. You can see here on the left images, those are the befores, and these are the after with the wavefront guided optics. This individual was much, much happier, and we see this repeatedly on our retrospective data for this, which is pre-publication. We've seen about a 1 to 2 line visual acuity improvement with a maximum of 5 lines and a reduction of residual aberration of about 50 to 60%. This was one of the cases that we had published. This individual experienced about a 67 and 64% reduction in aberration and a 2 line visual acuity improvement. with their wavefront guided scleral lens. So we're really in a very, very amazing time, and the Pentacam Wave AXL is really quite integral to this success. So with that, I'll go ahead and open it up to any questions and kind of stop right here.
Great, John, Steve. Wow, so much information to possess. I need to review this whole one more time. We've got a bunch of questions, but I know we've gone long on time, so I'm just going to ask each of you one question. Stephen, I'll start with you. We've had a bunch of questions regarding CTAC procedure, so I'll try to combine them into one long question for you. Can you tell us the difference in how you actually modulate a CTAC versus an intact? I know intacts are only available in one size, but what do you actually do to account for the variability and what makes the CTAC better? And also, how do you compare and contrast CARES to CTAC?
Sure. So good questions. So a couple things really are what makes CTAC advantageous to intacts. Because you're working with corneal tissue, you are able to place that corneal tissue sort of at any depth you want in the cornea. One of the things that we're most concerned about when you place PMMA segments like intacts is that if you place them too anteriorly in the cornea, they can extrude or you can have problems with them. So the ability to place the segments more anteriorly just in and of itself is a huge advantage to getting more flattening and more curvature change. In addition to that, and this is what really does separate the CTAC segment, Dr. Gelles, myself, Dr. Hirsch, we've worked for a long time on this, and actually with help of Oculus as well, and the Pentacam, we have worked on and developed a software that can actually analyze the topography maps that we generate from Scheimpflug imaging and from the Pentacam, and then it can actually develop a segment specifications to cut and place within the cornea, and that's really what has changed things. We're really customizing segments to each individual topography, and that's what's allowed us to modulate the flattening. So the different specifications that we use are through that software is what really is what allowing us to get much more predictable results. Some of the main differences, so CARES and CTAC are both corneal tissue inlays. The CTAC segment is always made from a femtosecond laser cut. So it is a cut that is made from the software. So it takes your topography or your patient's topography, runs it through a software analysis, which then develops an actual corneal inlay specifications for your patient. That then is sent to the femto laser, which cuts to those specifications. And then that is sent back to the surgeon to be placed with a surgical placement plan. So it's really it's the femto cutting and then in particular the surgical planning that really is what differentiates it the most.
Yeah, and I'm going to add to that in the area of contact lens, in co-managing these individuals. One, it's fantastic to have an option that really improves their visual acuity in glasses. It makes these guys functional. So instead of having patients who are, kind of running through or working through pain or discomfort while wearing, contact lenses, corneal gas perms or other things like that, these individuals are able to wear their glasses, be functional, and don't have to push through, which causes complications, infections, abrasions, those sorts of things. So these individuals have a much better quality of life, and as Dr. Greenstein was saying, have the the potential for a much longer period of time in their contact lenses at a healthier level. The other thing with it, when you compare it to intacts, is intact when you have a PMMA segment in the cornea and then a rigid contact lens resting on top of the cornea. You're essentially creating a plastic sandwich, which then can disrupt the epithelium overlying the segment, thus leading to inflammation and all the negative things that come along with that, like neovascularization, breakdown of the epithelium, and then eventually extrusion. These things can be entirely avoided because of the biocompatibility of the tissue, and because of the tissue size and shape, it does make it actually quite a bit easier to fit contact lenses over the top of these when compared to trying to fit a lens over an intact. So it's a much better solution.
Great explanation. John, one question for you. We touched upon putting toric IOLs in keratoconic eyes, and I know as a contact lens fitter, there's always been a lot of stories about how challenging that now become for the contact lens fitter. How do you handle it? Are you concerned at all? How do you choose which patients you would recommend a toric IOL, knowing what they're currently wearing or what they might be wearing after surgery?
Yeah. I mean, this really comes down to goals of the patient, likelihood of hitting an outcome. When we look at the way that me and Dr. Greenstein work together on this, and really this is what's fundamental to the success that we have with Keratoconus, is understanding, what the individual wants, and then us communicating about, what's going to actually work well for the individual, right? Are their goals realistic? Can we hit those goals? For individuals where they have, pretty good geometry after topography guided PRK and they're going in for cataract surgery, those individuals, I'm 100% for putting a toric IOL in, especially if they correct well on their manifest refraction. For those individuals who don't correct well on their manifest refraction, putting a toric lens is not necessarily going to help that much, and they're going to need to go back into their contact lens. So many of those individuals will say, all right, maybe not a toric IOL for that individual, but we also shouldn't fear a toric IOL because nowadays, because of all the contact lens options that we have, we're able to incorporate into lenses, rigid lenses, and custom soft lenses for individuals, the ability to have these toric correcting optics in them. So even if you do have a toric IOL in there, I can correct the vision in that. So it really depends on what they're in.
So I would say from the surgical perspective, one, I'm very lucky to work with Dr. Gelles, who is very comfortable fitting lenses over toric IOLs. So that has given me a lot of comfort putting them in, because if patients do need lenses after he has been able to fit them. But I would say that this is actually where your testing can be really, really important to making the decision about placing a toric lens. And that's where working through some of the things that we looked at tonight can really be very, very instrumental in that choice. So if you're looking at a patient's cornea and you look at their aberration profile, and particularly their corneal aberrations, and those aberrations are very, very high, and you're not planning on doing something about the cornea, you're going to need to be more hesitant about putting a toric lens in those patients. So unfortunately, with cataract patients, early cataract patients, we're still able to sometimes manifest in a meaningful way, but as their cataract advances, the manifest becomes more and more difficult. So it becomes less reliable in terms of being a metric, but you still have the ability to measure the corneal aberration profile and start to make educated decisions based off of the topography you see, that profile, as well as sometimes how the manifest axis still does line up with the corneal axis, even if their correction is not great, as well as their placido imaging and different forms of imaging as well. And if things line up, then generally they're good candidates for toric lenses. If you're seeing a lot of things that don't line up with a lot of aberrations in the cornea, those patients tend to do very, very poorly at toric lenses. So if you don't have the advantage of having the manifest refraction or a good manifest refraction, those are some of the things you can do to try to make that decision a little more easily.
So Steve, just for my clarification, when things do line up, do you do this sequentially? Do you do it simultaneously? And if so, which goes first?
In terms of like corneal correction versus
Exactly,
cataract
topo guided and toric IOL, if that's your plan.
Got it. So yeah, so you know, the topo guided in my mind is used to correct the corneal aberrations and the corneal topography before cataract surgery in general. So we will use some elements of PRK afterwards if we're still trying to work on more of a refractive result with a patient. But the true topo guided PRK and reshaping of the cornea is going to be generally most beneficial before, so that you can reduce the aberrations, improve the symmetry, and actually prepare the eye for either a toric. And I've actually had a lot of patients after their topo-guided PRK only require a monofocal lens.
Excellent. And how long do you normally have to wait after your topo-guided PRK? Is it?
Yeah, a long
6
time.
months?
So, yeah, 6 months. So that's the hardest part and the thing you have to prepare your patients for. And I always say the same thing. Month 3 or 4, they're usually want to rip my head off to because they can't wear a lens, they have no glasses that work, and they're waiting for the cataract surgery. And I really push them to wait for stability, because I've still seen change in that 4 to 6 month time period. And this is your shot to sort of get it right. But I will say that those same patients, usually by month 7, a month after their cataract surgery, even sooner than that, are usually ecstatic over the fact that they went through this process. So it's a little tough to carry through and hold a patient's hand through that length of time, but they do not regret it.
Oh, 100%. I will say they are some of the happiest patients, especially the ones where, you know, they've worn gas perms for 50 years and they just thought this is how life is. And, you know, after, you know, a sequential procedure are now free of lenses. It is remarkably life-changing for these individuals.
And one other thing I would point out, which can't be overlooked, is that as you get into the cataract age range and age brackets, you are working with patients who have more concern about their dexterity in the future, and they know what it takes to put in some of these specialty lenses, and they have real concern about what their life is going to be like if they get, even if they don't have it now, if they get to the point that they can't do that anymore. And so while a lot of patients, and we've shown some excellent results of some of the best patients that we've treated, even if you can't bring a patient all the way to 20/20 uncorrected, giving them significant improvement in their spectacle correction is really, really meaningful for them, both now, but also really for the future, and for alleviating a lot of their fears about life without a contact lens.
100%. I mean, a perfect example is that patient that had Parkinson's that we treated, that was, you know, that hand tremor, was very concerned about being able to get their lenses on and off going forward. And, you know, being able to give them a 20/30 result was, you know.
Right. Absolutely. Life-changing.
Wow. Well, I have so many more questions for you guys, but we're long on time, and I can't tell you how much I appreciate both of you sharing your expertise with us tonight. We'll have to do a part 2 and just do Q&A. But thank you guys so much tonight. And again, thank you everybody for attending tonight, and we look forward to our next webinar series. Have a great evening, everybody.
Great. Thanks for inviting us.
Take care.